topic that has been extensively discussed yesterday, and that's genomic testing and prognostic markers for early-stage disease. So rather than discussing the performance characteristics of these assays, I will talk about their usage and the clinical impact that it has made in the management of early-stage cancer in the United States. So in addition to covering the topics of usage, I also would like to touch a little bit on which tests to use and how these actually really compare with each other, and whether routine assays, since this generated a substantial debate yesterday afternoon, whether routine ER, PR, and HER2 measurements could really substitute for the more expensive genomic tests. And also would like to touch at the end on some of the, what I think are really promising forward-looking research projects in this field. So it's just barely about 5 years ago that the ASCO has endorsed the use of genomic multivariate assays to guide adjuvant chemotherapy selection for ER-positive disease. Subsequently, as you are well aware, the St. Gallen guidelines endorsed it as well as the NCCN. So this is a paper which looked at the usage of chemotherapy and the usage of assays in the early stage ER-positive setting in the very early years of genomic testing between 2006 and 2008. What this slide shows you is that in the yellow lines, it's a steady increase in the testing of early-stage disease, which is paralleled with a slight decrease in adjuvant chemotherapy use in the same patient population. Panel C on this slide shows you that the uptake was slightly different between academic centers and private practices in the United States. So academic centers were a little faster in taking up and adopting these assays in these early years. However, this is the data that's currently available, and there is no more sort of up-to-date information on this subject, but I'm quite convinced that the number and the usage of these tests has increased since 2008 further. So what percentage of patients are tested? That, of course, depends on the clinical characteristics. So this slide illustrates that the test is mostly used between 50 and 69 years of age. The usage has increased from about 14% to 27% from 2006 to 2008. And those who are tested are primarily stage 1 and stage 2 disease. And again, it's the low and intermediate grade, histologic grade population where the test is used, and it's about 20% of the patients which are actually sort of tested to guide or help with the adjuvant treatment decision. So another way to address this is to look at what is the distribution of the patient characteristics among those who are actually being tested, as opposed to the previous slides, which look at the entire population and try to look at what is the segment of the population that's being tested. So among those who are tested, the vast majority in this particular academic center, which was my former place at MD Anderson Cancer Center, we looked at how me and my colleagues used the Oncotype DX assay in somewhere between 2005 and 2009. So 80% of the patients were stage 1 and stage 2. Virtually all were lymph node negative, and the next slide shows that they tend to be in the intermediate grade 2 category. So another important thing is what happens with the results. So do people actually act on it? There are several small studies which queried physicians. What would they do just based on the routine clinical information that's available for them and how this treatment recommendation changes once they have the test results. So all of the studies which examine this question conclude that about 20, 30, or 35% of the time, the treatment recommendation is changing. So much larger studies, which did not directly address the question, what would you do in the absence of test versus with the test results, looked at associations between how chemotherapy is used among those who are tested compared to those who are not tested, keeping everything else or trying to keep everything else, including clinical stage, the same. And a very interesting pattern emerges here. So what this table illustrates for you is that in the low-risk population, chemotherapy usage tended to be increased when the assay results were available. That, of course, makes sense because the default is probably not to recommend chemotherapy. So for some reasons, people suspect that the clinical variable-based risk assessment may not be quite accurate, so you order the test, And if the test comes back as high risk or intermediate risk, you act on it. And therefore, clinical chemotherapy usage has to increase. So conversely, in the high-risk population, chemotherapy usage actually went down. And the largest segment of the population that is being tested, remember, is the intermediate risk, the clinically intermediate risk group. And in that risk group, also the usage actually went down in those who has been tested compared to the population who has not been tested. So these two types of evidence, direct questioning of the physicians and this indirect assessment of chemotherapy use in the context of testing, both suggest that overall chemotherapy usage is decreasing with the test. But how you use them, when you order them, will have a major impact on the cost effectiveness of the test, of course. So which test to use? So with every good product, obviously a lot of other products will appear to sort of compete or give additional sort of options in the same niche. So this is a little selection of the various tests which are available on the market to risk stratify ER-positive cancers. And I'd like to point out that I probably don't do justice to all the companies who are in this space, because there must have been a few companies which were founded overnight or in the past couple of days since I completed this set of slides. It's very easy to actually come up with a prognostic marker for ER-positive cancer. So which test to use? So all current genomic prognostic tests derive their prognostic values from quantifying proliferation or ER signaling. And both of these are very large dominant signatures. That's the reason why it's relatively easy to come up with prognostic signatures for ER-positive cancer. They all accomplish similar prognostic stratification in the ER-positive population. And they are all supported by similar types of evidence. And of course, all the tests have more supportive data. And that supportive data is entirely sort of correlative or associative rather than direct testing of clinical value. Although there are several clinical trials, and I listed MIND-ACT, TAILOR-ACT, RX-Sponder, POETIC, and OPTIMA, which prospectively study the clinical value of these tests. I don't think that there is any reason to believe that they would not prove the value of these tests. But it's important to keep in mind that the way we are using it is really sort of based on the assumption that they do provide improvement in clinical outcome, or at least save some people from chemotherapy, and through this provide some added value. So when you have multiple tests available for you, then inevitably comes the question, what happens if you order more than one test on the same individual? I think it's very important to understand that if you order more than one test, you should expect discordance. So that's totally expected, and it will never go away. So you can't really expect that different tests which rely on different types of measurements, even if they capture the same biological principles, would yield a very high concordance. But of course, this also raises the problem that what happens when you have discordant results. So I think the solution to this is that you probably should not order more than one test, because each of these tests really carry the same prognostic value and do the same discrimination, and try to avoid sort of double-checking the results unless you are doing this with a very sort of large clinical trial context, because you would need a very large clinical trial indeed to find out how the discordant cases do, which assay actually predicts better. So this is just an example from one work that we have done a few years ago when we applied the same clinical specimens to standard commercial assays. One of them was the Oncotype DX used for routine purposes, and the other one was the PAM50 prognostic sort of classification schema. And what you see here is what have been seen from time and time again, and if you want an easy publication, that's the way to do it. You just compare two different predictors. So of the luminal A cancers, which are in the red box, about 70% were low risk by recurrence score, the remaining 30 intermediate risk, which is good. So the luminal B cancers were mostly intermediate or low risk again, but a large number of them were intermediate risk categories, and a few ended up as high risk by the recurrence score. And some of these patients actually turned out to be HER2 enriched or basal-like by the PAM50 assay. So we actually probably had one false positive ER in that cohort of around 100 patients. This is really illustrating the same point again. where we applied to the same patient population of around 300 patients who received neoadjuvant chemotherapy and had long-term follow-up. But 6 different genomic predictors were their surrogates. So in this particular setting, the 21-gene Oncotype DX assay is not the real Oncotype. It's its sort of genomic equivalent. And the same with the molecular classifier. It's an equivalent of it. It's not a commercial assay. But again, the data is very, very consistent. But it shows you that these assays pretty much perform similarly in terms of their AUCs or predictive characteristics. And they predict both prognosis and also survival, and also chemotherapy sensitivity or pathological CR rates with fairly similar performance characteristics. And of course, the colorful panel there shows you the agreement between the risk assignments. So blue is good risk, red is bad risk, and by and large, the results are concordant with one another. But as I told you, you can't really expect a very high level of concordance, so there is a fair amount of discordance in the overall risk assignments, which is, again, centers around 30%. So finally, this is the most exciting question, right? So can routine ER, PR, and HER2 and Ki67 accomplish the same results? So this is actually a really good question. This is a question that is designed to generate controversy. Like any good questions that lead to fights and good arguments, it's a very vague question, which means that each of us actually understands a different thing when we actually ask this question. So naturally, the response is both, yes and no. So here is how the yes group would go. So there is very good data, which really shows that taking ER, PR, and HER2, you can accomplish the same risk stratification as you could do, for example, in this example with Oncotype DX, the recurrence score. But I'd like to point out to you that to do this, you really need to do this rather complex mathematical calculation, which is in the upper panel. So this is not just simply categorical variables that you are ER positive, PR positive, HER2 negative, whatever. It's really a complex mathematical formula. And you also have to realize the standardization, that the assay has to be done in a very standardized fashion. Otherwise, the thresholds won't travel between laboratories. So yes, these markers could accomplish the exact same thing, assuming that you're actually willing to do the calculations and you really have a very highly standardized assay. And you need to validate this in your own hands, because currently it looks like that the thresholds and the numbers that one laboratory establishes don't really travel well to another laboratory. So that's the issue that we discussed yesterday about the reproducibility between laboratories of particular numbers. And this is the argument why this is not the case, because the way we use these variables today is really categorical variables. So you are either ER positive or negative, HER2 positive or negative, because we can't really do the mathematical calculation for a multivariate assay in our heads. So with 6 markers, actually with 4 markers, you get 24 different groups. Even if you discard HER2, you still get 6 different groups. It's not, I'm pretty sure that none of us actually can track the outcome of all the 6 groups. And even if you collapse them, you start to dilute the value of these markers by collapsing the groups together. And still, you probably won't be able to remember the outcome results. So more importantly, there was a very elegant presentation by Kirsten Denkert at the San Antonio meeting last year. And I'm grateful for Kirsten to share the slides with me. What the insert on this slide shows is that there is really no threshold for Ki67. Pretty much of a very broad range, the prognostic or predictive value of Ki67 remains significant. So what this means is that really the best way to use this as a continuous variable in a multivariate assay rather than a threshold-based analysis. So the most important thing that I would like to really convey is that genomic prognostic tests do not just quantify ER, PR, and HER2 and Ki67, but combine these into a mathematically sort of valid statistical multivariate prediction model. So finally, I'd like to say a few words about what I see is the near-term future for these assays. So clearly, it's becoming increasingly important to identify the ER-positive patients who benefit and would require extended adjuvant therapy beyond 5 years. So there's a lot of research about predicting recurrence and local recurrence in invasive cancer and in DCIS. So it looks like that the same variables that we are using to predict distant recurrence actually also predicts for local recurrence. although the weighing of the variables and their accuracy of the test for local recurrence, for recurrence in the context of a DCIS, may be different. And ultimately, I think the next generation of these tests will need to include both the clinical and the genomic variables because they are complementary to each other. So the best risk prediction would come by integrating them together, but not just by our guess, but by really building these variables into a model. So just to remind you that there are 4 different clinical trials which have now shown the value of extended adjuvant endocrine therapy. But there is a price attached to the gain that we get in saving a woman from breast cancer deaths. So this is a little bit of a calculation that I have done on the Atlas trial, which was published in Lancet last year. So it looks like that we would need to treat around 340 patients to save 6 deaths from breast cancer. But at the same time, we cause about 3 extra endometrial cancers and 3 extra ischemic events and 1 pulmonary embolism in that population because of the tamoxifen. So that underpins the importance of trying to really streamline the use of these drugs. And one limitation that the current first-generation genomic tests have is that we somewhat overlooked the time-dependent interaction between ER and PR in terms of predicting recurrences. So the prognostic value of ER and PR varies over time. And this is a really interesting analysis that we have done a few years ago in collaboration with Luca Gianni and Gianpaolo Bianchini. So we looked at the late recurrences as a function of proliferation and ER signaling. And this shows something really interesting. So I wonder if this actually will work. So, so I try to highlight for you, but instead of highlighting, I just like to focus on the blue bar. So that's the patient population which have a very high proliferation and low ER. So they have poor prognosis. But all of their recurrences happen in the first 5 years virtually. So they behave like triple-negative disease. So if you made it out for 5 years, you may not need extended endocrine therapy because your subsequent risk is low. If you have very high ER, very low proliferation, then you also do very well. The long run and the short run too. But what happens to the 2 groups, the yellow and the light blue, is really interesting. So particularly the light blue group, because these are high proliferation and high ER patients, and they do very well in the first 5 years while on endocrine therapy. But when you stop that, they start to recur. And in fact, they have a higher rate of recurrence after 5 years than they had in the first 5. And another steady group where there is a steady increase over time is the folks who have a low proliferation and low ER. It's questionable whether we can actually change their outcome because they have a very low ER and a very indolent tumor, but it's a bad tumor which keeps recurring. On the other hand, the light blue group may be the group which really benefits. So that's the hypothesis, the therapeutic hypothesis that you could derive from this analysis. So it's very nice to see. So we presented this about 2 years ago, and since then, a number of other studies actually have really confirmed the similar sort of time-dependent interaction with ER and proliferation-related genes in terms of late recurrences. So again, I'm very grateful for Dennis Croy, who shared his slides with me that he presented at the San Antonio Breast Cancer meeting. And this is the breast cancer index, which is a combination, sort of a proprietary combination of the genomic grade, the molecular grade index, and some ER-regulated genes. And what they are showing here is something very similar that I have shown to you before, that the recurrence is in the 0 to 5 years, and recurrence is in 5 to 10 years. And I would like to focus on the purple line. So these are the folks who are low risk at the beginning, low risk throughout. But then there is a group, the light blue group, which crosses over. So they have a relatively low risk early on, but then their recurrence rate increases after 5 years relative to what it was in the first 5 years. So this collaboration that they had with the Trends ATAC group also gave them an opportunity to compare the early and late relapse predictive values of 2 other prognostic signatures or prognostic assays, the immunohistochemistry, the IHC4 score, and the recurrence score. And what the little bar graph shows on this slide is that these the IHC4 and the recurrence score had less of a predictive value for late recurrence than the breast cancer index. So in the same way, there was a very elegant presentation by Peter Dubski, and again, I'm grateful for him to allow me to show this slide from his presentation. Again, last year at San Antonio, the EndoPredict, which is the same sort of idea that you can combine proliferation and ER markers, and by weighing them appropriately, you can actually get predictions for both early and late relapses. So the very last slides about predicting risk of recurrence in DCIS, since I was asked to talk about the value of these genomic tests in non-invasive cancer. So the value of these tests in DCIS is very unclear as of today. There is really only one study that I'm aware of that showed sort of some value to testing DCIS for local recurrence. And the background to this is shown on this slide. So this shows you the improvement in terms of reducing ipsilateral invasive and ipsilateral invasive and non-invasive recurrences by doing radiation therapy after lumpectomy. This is from the Lancet. And of course, the overall survivals or breast cancer mortality doesn't improve, but the recurrences do. So Genomic Health undertook a re-optimization of the Oncotype DX score to try to predict local recurrence in DCIS. So the same genes are measured, but they are weighed differently. So the model actually has a different formula than the recurrence score for invasive cancer. Yeah. So this assay actually showed that again, you can categorize people into high, intermediate, low risk, and if you have low risk, then you have a lower rate of recurrence, even in the absence of any radiation therapy in a trial where there was no radiation therapy, just surgery alone. But I'd like to point out to you that even the low risk group actually has about 5% risk of ipsilateral invasive recurrence and 12% non-invasive recurrence, which are probably too high to really do away with radiation therapy even in these groups. So this is my last slide. And I'd just like to repeat them. So genomic testing is ordered about 20% of patients with stage 1, 2 ER-positive node-negative cancers, and I think this number probably is larger today. So treatment recommendations are changed about 20–30% of the time as a result of the test result itself. And overall, test use is associated with decreased use of adjuvant chemotherapy. So routine ER, PR, and HER2 measurements used in combination as binary categories are not the same as a multivariate genomic predictor such as IHC4. So the ER and proliferation have a time-dependent interaction with recurrence, so you would need to weigh them differently to be accurate in the first 5 years versus the second 5 years. And it's a very important thing to remember that just measuring your risk of recurrence is probably not enough to really conclude that these are the people who should get therapy, because there is another component to benefiting from extended adjuvant therapy, and that's continued chemotherapy or endocrine therapy sensitivity that these tests may or may not measure. And to show that, we would really need to apply them to the extended adjuvant therapy trials. And finally, genomic prognostic predictors may also become available for DCIS, but that's only based on a single study, and more studies are needed. Thank you.